Hey, welcome to part 3 of Introduction to Radiobiology. In this lecture, we'll discuss the risk models and quantitative radiation risks, as well as the linear no-threshold model and uncertainties at low doses. We'll also briefly cover radiation hormesis and special spatial and temporal effects, such as the bystander effect, abscopal effects, and genomic instability. This lecture is heavily based on the textbook by Bushberg, The Essential Physics of Medical Imaging. So, how do we define risk? Well, to evaluate the health effects of radiation on exposed persons, the incidence of a certain effect is studied in both the exposed and non-exposed control group. Risk estimates derived from such studies are generally presented as relative risk, excess relative risk, or excess absolute risk. Absolute risk models assume that radiation induces cancer over and above the natural incidence, but independently to it. Relative risk models assume that the effect of radiation is to increase the natural incidence at all ages after exposure by a given factor. Note that the relative risk model is favored by the BER committee. As previously described, the relative risk is the ratio of disease incidence in the exposed population to that in the general population. So a relative risk of 1.2 indicates a 20% increase over the background rate. The excess relative risk is defined as the relative risk minus 1, in this case being 0.2. And this would still represent a 20% increase over the background rate. Excess absolute risk is the number of excess cases, usually per capita, here for example, per 100,000 in a population. As an example of quantifying risk, let's say we have a clinical trial where some patients are expected to receive 4 CT-guided biopsies, 14 neck, chest, abdomen, pelvis CTs with contrast, and 9 F18 FDG PET CT scans. This is quite a lot of imaging, and so we would be interested in estimating the risk associated with these schedules. So, if we can perform dosimetry and estimate the risk to the patients following this imaging, people can decide, is it worth taking these risks, weighing up all of the clinical factors outside of radiation risk. Radiation-induced risks depend on various factors, such as age, sex, and cancer type. For example, the risk of ovarian cancer from an acute exposure at age 10 is about 3 times greater than the same exposure at age 50. For a whole body exposure, females have an average 40% higher risk of radiogenic cancer than males. Finally, the minimum latency period for leukemia is 2 to 3 years, whereas the latency period for solid tumor ranges from 5 to 40 years, having implications on risk. Here, let's walk through an example of quantifying excess risk. So for a cancer with a radiation-induced risk of 4 times 10 to the minus 4 per sievert per year and a minimum latency period of 10 years, the risk of developing cancer within the next 40 years from a dose of 0.1 sievert can be calculated as follows. So in the next 40 years, we have to exclude the latency period of 10 years. So we can multiply our risk factor by 30 years. We also know that the doses are 0.1 sieverts, so multiplying our risk factor with that dose, we get 0.12%. So if 10,000 people each receive a dose of 0.1 sieverts, the 0.12% results in 12 additional cases of cancer that can be expected to develop in that population in the subsequent 40 years. Now, going back to the example of the clinical trial, if we want to provide the appropriate information for a human research and ethics committee, we need to calculate the dose and estimate the risk so that patients can be well informed and their procedures justified. So as we've seen, the first step is to calculate dose. Thankfully, as physicists, we have software available, such as NCI-CT, MERD-CT, CT-Expo, and so on. You can see on the right here a screenshot of MERD-CT, one of the examples. Now, all of these software packages calculated doses using direct Monte Carlo simulations. An alternative approach for radiopharmaceutical therapy or nuclear medicine are in-house scripts combined with S-factors to perform voxelized dosimetry. As an example, let's say we're using CT-Expo to calculate the dose associated with the CT parts of these patients' imaging. This software is free to use, it has its limitations, but all you need as an input to this software is the CTDI vol, the DLP, and the anatomical coverage of scanning. We can estimate all of these from the Monash Health Facility reference levels. So you've input the parameters into the software estimates the dose and provides the absorbed dose to all of the organs, as well as the total radiation dose received for this imaging schedule was 242 millisieverts, including the PET aspect of imaging, though this was calculated in a separate manner. So we've estimated the dose to be 242 millisieverts. According to the radiation protection standards, this dose would fall into this category of effective dose greater than 50 millisievert. And below is the associated risk statement that you would provide to the HREC committee. We can see here that the annual dose that we receive from background radiation, which is unavoidable, is about 2 millisieverts. So the effective dose of 242 millisieverts is equivalent to about 121 years worth of background radiation. Shown here is a table of the lifetime risk coefficient for cancer incidence from a single whole body exposure to 100 milligray. Now, as we've seen in this trial, the patients received 242 millisieverts of effective dose. Now, assuming that we have a case of 240 milligray whole body exposure and that our patients are 20 years of age, averaging the risk coefficient across sex, we have about 0.01 for 100 milligray, but 0.024 for patients receiving 240 milligray. So 1 over 0.024 is about 1 in 42. So in this risk statement, you could say that in this particular study, the risk is moderate, and the estimated risk of such harm is about 1 in 42. However, for a clinical trial such as this one with such a heavy imaging schedule, participants of such a trial would have a very short life expectancy of, say, 6 to 12 months. And in this case, it doesn't really make sense to estimate risk, as one of the assumptions in these calculations is that there will be enough time for the cancer to develop, and this isn't accounted for the 6 to 12 month life expectancy. So a risk statement that you would provide would not estimate a risk based on such a calculation. We've seen how we can calculate risk based on numbers we found in tables provided by, for example, the BR committee, but where do these numbers come from? Well, they're based on the linear no threshold, or LNT model. Population data that form the basis of known bioeffects come from atomic bomb survivors, patients with medical exposures, and persons with occupational exposures. These known effects are measured in this high radiation dose region. So the LNT model, or linear no threshold, extrapolates down to low doses to be able to estimate biological effect. This linear no threshold model has its weaknesses. It's very difficult to detect radiation risk at low doses because radiation is a relatively weak carcinogen. The natural incidence of cancer is high and has a long latency period, and there are many subtle confounding factors. All of this gives rise to weak statistics. And you could say it's equivalent to trying to find the needle in Claude Monet's haystacks. Several models have been proposed to characterize dose-response relationships of radiation exposure. The shapes of the curves can be described as linear no threshold, linear quadratic, and threshold. There is epidemiological evidence for a threshold for some cancers. For example, a threshold model provides the best fit for osteogenic sarcoma risk among those dial painters who had substantial internal radium contamination. Other cancers consistent with the threshold include bone, soft tissue, sarcoma, rectum, and non-melanoma skin cancer. There are also sites for which there is no solid evidence for a radiation-induced increase in cancer risk, such as the prostate, pancreas, testes, and cervix. There are multiplicative and additive risk models. The multiplicative risk model is based on the assumption that excess cancer risk increases in proportion to baseline cancer rate, so that excess risk is a multiple of natural age-specific risk in that population in question. The additive risk model is based on the assumption that following a latency period, excess cancer rate is constant and independent of the spontaneous population and age-specific natural risk. These models are important because they can be used to transport risk calculated from one population into another one. This is critical because, as we've seen, much of the models are applied to data from atomic bomb survivors in the Japanese population. So, the natural incidences of cancer in Japan are different to other places like the USA. For example, breast cancer incidence in the US is 3 times that of Japan, and liver and stomach cancer are 7.5 and 10 times higher in Japan than in the US, respectively. Let's walk through another example. How do we estimate risk for different sites? Let's say a 10-year-old girl receives 20 milligray breast dose from a chest CT exam. Now, using our table adapted from the BIR7, the lifetime attributable risk of site-specific cancer incidence. This has given us the number of cases per 100,000 persons exposed to a single dose of 0.1 gray. Now we have the age at exposure and the cancer site in men and women. So, looking at our example, the breast for a girl 10 years old gives us 712. Now, we know that the dose is 20 milligray, not 0.1 gray, and making the LNT assumption, which is that the risk scales linearly with dose, we can multiply our 712 by 20 milligray over 100 milligray, which gives us 142 per 100,000, or 1 in 700. Now we can also see that if the same dose was received by a 50-year-old woman, the risk would drop by a factor of 10. Indeed, going to this column, which is 50 years old, we have 70 instead of 712. The use of medical imaging using ionizing radiation has drastically increased over the last couple of decades. There's been a growing awareness of potential overutilization of this technology and its associated risks, particularly for a pediatric patient population that inherently has high cancer risk from radiation exposure and that may receive higher organ doses as they're given adult protocols. Physicians must be aware of these issues, and efforts must be made to optimize the technical factors in image acquisition and consider the appropriateness of requested examinations. You can see here how much greater the cancer risk is for lower ages, with pediatrics in particular. The lifetime probability of developing cancer in the USA is about 41%. The US population average radiation-induced cancer incidence per sievert is 11.4%. So looking at the right, if 100 people each receive 100 millisievert, or 0.1 sievert, then the incidence would be about 1.14, or 1. So you can see that with those people receiving this dose, there would be one additional person developing radiation-induced cancer on average. Though it's important to note that there's no way of identifying which person has the additional cancer caused by radiation exposure, and if it occurred at all. The use of the linear no-threshold model is well established in radiation safety regulations, but is subject to disagreement in the scientific community. Controlled experiments and animal studies have contradicted the LNT model, as many of these have shown adaptive responses to low-dose radiation in the form of reduced mutation in cancers, which demonstrate a phenomenon known as radiation hormesis. As an example, in the 1980s, a number of buildings built in Taiwan using steel, unknowingly contaminated with cobalt-60, exposed thousands of residents to low-dose radiation for a number of years. Detailed dose estimation performed for the group indicated that the average excess dose received by residents was about 0.05 gray, which is similar to the average of doses received by the two lowest dose cohorts in the atomic bomb survivor data. The cancer incidence for residents has been monitored, and the incident number of solid cancers is lower than what is predicted by the LNT model. A significant reduction in all cancers was also reported, and this remained true in a later follow-up report. Essentially, the study implied that if the bias that was found is applied to the atomic bomb survivor data, you would obtain a negative excess relative risk value at low doses, which implies that low doses of radiation make you less likely to get cancer. Another example, but from the radiation therapy context, is that it was reported that tissues that had received about 0.2 gray were found to have reduced cancers compared to the unirradiated tissues that had received no dose. A study showed that low-dose radiation broadly applied to half the body for non-Hodgkin's lymphoma patients in between radiation therapy treatments to the primary tumor resulted in reduced metastases and improved patient survival compared with standard treatment alone. To go even further, some researchers have proposed the idea of using hormesis to reduce cancers, and this has been advocated for in recent times. This is a big step further from a suggestion to change radiation policy and safety guidelines for low-dose radiation exposure. Some claim that inaction in studying radiation hormesis in humans since the time that it was proposed has contributed to preventable cancer deaths, and they urge for prompt action. They also talk about economic and social costs, which are important to consider in the context of policy. For example, some authors might say that the money spent on excessive amounts of lead shielding could be poured into other means of saving lives. The LNT model is indeed subject to some limitations. The DNA repair mechanisms evolved in a much higher background radiation level and are efficient at repairing low-dose exposures. The LNT model doesn't account for evolutionary factors. The LNT model also assumes that radiation damage and associated cancer risk are cumulative. This assumption is not consistent with DNA damage repair and cellular turnover and elimination. The LNT model assumes that any mutation may lead to a potentially lethal cancer. Although DNA damage in the form of initial mutations may be a necessary prequel, the failure of many other defense mechanisms is required for carcinogenesis. The average natural background radiation dose on Earth also varies from 1 to 260 millisieverts. But there's been no associated adverse health effects proportional to radiation dose documented anywhere in the world. In fact, some high background areas have the same or lower cancer rates compared with nearby areas with low background rates. Some studies of populations exposed to low levels of radiation have documented benefit from these exposures. You can see here a few studies on radiation hormesis that you may use for reference. The key takeaway is that there is no evidence that can definitively confirm or eliminate the existence of a dose threshold for carcinogenesis, scientifically. In terms of radiation protection and regulation, we use the linear no-threshold model. The biological effect of radiation is indeed more complex, as evidenced by certain special processes, such as the bystander effect. This is a phenomenon where irradiated cells induce biological effect in neighboring unirradiated cells. These effects can be seen both in vitro and in vivo, and are often linked to intercellular communication. The mechanisms include the release of signaling molecules into the extracellular medium, gap junction communication, and exosome release. Bystander effects result in DNA damage, altered gene expression, genomic instability, chromosomal aberrations, and increased incidence of lethal point mutations. Some of the in vitro effects include microbeams only targeting the cytoplasm, or microbeams and particle beams affecting some cells more or less than others. Another example is abscopal effects, which are systemic in nature. These refer to radiation-induced effects observed in distant, non-irradiated tissues or organs far from the site of direct irradiation. These effects occur through immune-mediated responses and cytokine signaling, which involve the release of damage-associated molecular patterns, or DAMPs, that activate systemic immune pathways and the circulation of molecules that mediate systemic effects. These processes result in tumor regression at sites distant from the irradiation field and enhance anti-tumor immune response. This is especially important in the context of combined immunotherapy and radiotherapy. Those two effects are spatial effects. Genomic instability is defined as a state of persistent genomic alterations that increase the likelihood of further mutations in progeny cells after an initial radiation exposure. The mechanisms include primary damage, failed DNA repair, reactive oxygen species, and epigenetic changes. Experimental evidence also exists for both in vitro and in vivo studies. This effect results in increased mutation rates over generations, chromosomal aberrations, telomere shortening, and persistent activation of stress response pathways. The biological consequences of genomic instability include cancer development, malignant transformation of normal cells, accelerated aging, and chromosomal damage in the offspring of irradiated cells. This effect has clinical implications in radiotherapy, low-dose radiation risk assessment, and in the search for predictive genomic biomarkers. So genomic instability extends the effects of radiation far beyond the initial exposure, making it a temporal effect. Thank you for listening. I hope that you enjoyed or got something from the video. Please get in touch with us if you have any questions. And a final reminder that this lecture is heavily based on the textbook by Bushberg, The Essential Physics of Medical Imaging. Thank you.